Abnormal fetal heart rate monitor. Remember that is our ultimate sole rule in labor room to work as team. Abnormal fetal heart rate pattern. It's vary in the abnormality between the fetal heart rate, fetal heart variability, fetal heart presence of deceleration and type of the deceleration, and others. Fetal heart rate difference. It can be either increase in the heart rate, which is tachycardia, or reduce in the heart rate, which is the bradycardia. What could be the possible causes of fetal heart rate tachycardia? Before we talk about fetal heart rate tachycardia, we have to define fetal heart rate tachycardia. It's more than 100 beats per minute, lasting for more than 60 minutes. If it's lasts for more than 60 minutes, it's not amber, it is pathological. Increase in the heart rate could be due to the maternal causes or due to the fetal causes. Maternal causes like anxiety, fever, medications, or epidural analgesia. Whereas fetal causes like benign causes like fetal tachycardia, movement stimulation, fetal hypoxia, early sign of hypoxia like prematurity and fetal infection, increase in the baseline heart rate even within normal range with other non-reassuring or abnormal features should increase the concern. Where fetal heart rate below 110 consider be bradycardia. Between 100 and 109 it's considered suspicious or amber, where if it is less than 100 it's considered to be red. There is multifactorial can affect it and cause suspicious fetal heart rate bradycardia. Benign causes like you can identify if it's benign with good variability and no deceleration. Other causes like narcotics, epidural analgesia itself led to an increase in the incidence of maternal hypotension. Medication can produce bradycardia approximately 5 minutes following the block for as long as 10 minutes. Maternal hypotension and oxytocin use and post-term infant per se and fetal position like occipito-posterior and deep transverse arrest. What are the causes of fetal heart rate bradycardia? What is the possible causes of pathological fetal heart rate bradycardia? Could be fetal heart block or other condition like maternal systematic leukodermatosis and congenital heart disease of the fetus. Prolonged fetal bradycardia could be due to the cord prolapse, prolonged compression of the cord, or abruption placenta. So if bradycardia occur more than 3 minutes, if the fetal heart rate not recover by 9 minutes, urgent preparation should be made to urgent expeditions of the birth of the baby. If the fetal heart rate recover by 90 minutes, this baby, this maternal condition should be reassessed by senior consultant, and he or the consultant in call, and he will decide if he will continue with the process of the delivery or he would wait. Is it maternal heart rate? Is it bradycardia? Is it prolonged deceleration? To differentiate between maternal heart rate and fetal heart rate, we will tackle it in separate lecture. But what about is it bradycardia or prolonged deceleration? There is no consensus agreement between all the guidelines whether this is bradycardia or prolonged deceleration. Some guidelines they will consider a 3 minute or more as a prolonged deceleration. The other they will consider it as a bradycardia. I am with the more than 3 minutes to be considered as a bradycardia. And if you ask me why, I will tell you the same effect whether it is a bradycardia or prolonged deceleration. It's carry the same effect. If it's pathologically occur, then the heart rate dropping below 100 and the prolonged is going to affecting the base deficit of the fetus reflected on the pH later on. Whether we are talking about prolonged deceleration or bradycardia, Although the umbilical cord compression is often responsible for the prolonged deceleration, pelvic examination should be performed to rule out umbilical cord prolapse or rapid descent of the fetal head. Maternal hypotension, uterine hyperactivity, cord prolapse, cord compression, abruption placenta, artificial maternal heart rate, maternal seizure, all they can be the cause of prolonged deceleration or bradycardia. Prolonged bradycardia results in progressive fetal hypoxia and respiratory acidosis and ultimately metabolic acidosis and result at the end in fetal death. Fetal heart rate variability is under the influence of the parasympathetic nervous system. We have the long-term variability, it's 5 to 15 over beat fluctuation over 1 minute, and this is what we call the cycle of the variability. And there is the short-term variability, which is 2 to 4 heartbeat every 1 to 2 seconds. If you look to what is causing this variability, it is due to the vagal impulses from the midbrain affecting the SA node. So whenever the vagal is stimulated, this will lead to the drop in the heart rate. And if the vagal is disappear, this is lead to increase in the heart rate. So vagal stimulated, drop in the heart rate. Vagal effect have been released, this will lead to increase. Why? Because the dominant effect is the sympathetic. The sympathetic will be suppressed by the vagal stimulation. So the sympathetic acting, once the parasympathetic start to act, then the parasympathetic will be leading to reduction in the heart rate. So vagal is parasympathetic, stimulation of the vagal or parasympathetic drop the heart rate, release of this parasympathetic or vagal effect, then back to the dominant, which is the sympathetic. Fetal heart rate variability varies. So we are talking about the long-term variability. We are talking about either there is decrease in the long-term variability, which could be physiological due to the sleep cycle of the baby, but shouldn't exceed 40 minutes, or it could be pathological due to the chronic fetal asphyxia or acute fetal hypoxia. Variability also could be moderate variability, which is normal variability 6 to 25 beat per minute, or could be marked variability, which is saltatory variability, and we divide it into the physiological and pathological, and can be also sinusoidal fetal heart rate pattern, which can be also physiological and pathological. Remember that the origin of the fetal heart rate variability is complex, with input from other cycle physiological systems. The fetus requires integrity of the cerebral cortex, midbrain, vagal nerve, and the cardiac conductive tissue to exhibit normal fetal heart rate variability. The fetus with normal fetal heart rate variability is at lower risk of immediate death or brain injury caused by asphyxia, regardless of the presence of the deceleration or bradycardia. Remember that decreased variability may occur in the following situation: hypoxia, acidosis, nervous system depressant medication, fetal sleep. Decreased variability is especially ominous if it's associated with late persistent deceleration or repetitive severe prolonged deceleration. What is sinusoidal fetal heart rate pattern? A sinusoidal fetal heart rate pattern described as a regular oscillation of the baseline that resemble a sine wave. It is a smooth, undulating pattern lasting for at least 10 minutes with a frequency of 3 to 5 cycles per minute, an amplitude of 5 to 15 beats per minute above and below the baseline. Baseline variability is absent, and the sinus wave form may be confused with a good baseline variability. Can a sinusoidal fetal heart rate pattern be physiological? The answer is yes, in thumb sucking by the fetus and in hiccup, where pathological fetal heart rate pattern can be due to fetal anemia. Remember that IV, Demerol, or Betadine can cause sinusoidal fetal heart rate pattern in 15% of the cases. Remember that in the presence of abnormal fetal heart rate pattern and uterine hypercontractility, not secondary to oxytocin infusion, tuberculosis should be considered. In cases suspected or confirmed acute fetal compromise, delivery should be accomplished within a time appropriate for the clinical condition. Remember that whenever you diagnose CTG as amber or red, you have to do resuscitation of the woman. Resuscitation starting by left lateral position of the woman, and will decompress the inferior vena cava from the gravid uterus, reduce or stop any oxytocin, initiate tocolytics, and applying internal monitoring to verify the accuracy of external monitoring reading. Administer amnioinfusion research and have been proving it's effective in cases of oligohydramnios, and fetal blood sampling if it is available. When you are doing resuscitation, prolonged use of maternal facial oxygen therapy may be harmful to the baby and should be avoided. There is no research evidence evaluating the benefit or the risk associated with short-term use of maternal facial oxygen therapy in cases suspected fetal compromised.